Buenas tardes a todos. Me gustaría agradecer la invitación, Guillermo, la invitación de PANCCO. Yo no hablo yo hablo portuñol y no español, como ustedes ya saben. But thank you, Guillermo. I would like to call Dr. Uma Mahadeva. Say perfect, okay. Who really needs no introduction. The importance of the studies conducted by her related to pregnancy and fertility. She has a great experience, and she's a gastroenterologist in UC San Francisco, right? Thank you very much to be here with us.
Okay. Hola, ¿cómo está? ¿Bien? Yeah. Muchísimas gracias para la invitación hoy. My talk today is de las mujeres de IBD con embarazada. Okay, the rest is in English. I just wanted to do better than Miguel. Mi esposa es de Argentina y habla un poco de español, pero no para el médico. Okay, so I am going to talk about the global consensus for the management of pregnancy and IBD. And the global consensus was met at DDW in May of this year. And you can see you have some of our colleagues from Central and South America here. And the point of the global consensus was to have one guideline with everyone who participates in the care of women with IBD around the world participating and agreeing on what this is. Because we all look at the data and come up with different guidelines, which is confusing. And the global consensus, so if you go on the pianostudy.ibd website, once the paper is approved, there will be the slides that you can download in English, Spanish, and other languages. There will be a patient video in English, Spanish, and other languages. And the PDF of the actual paper will be translated into multiple languages, courtesy of DeepL. So your Spanish-speaking patients and your Spanish-speaking doctors can look at the slides, look at the video, and be able to see this in their own language. So why do we talk about pregnancy and inflammatory bowel disease? 50% of people with IBD are women, and pregnancy is a period of intense immunologic change. There are changes to the microbiome, there's changes to the immune system, and the placenta is one of the most highly immune organs there are. And the human placenta is very different from any other creature. In every other animal, the placenta sits on top of the uterus. In humans, it's the only creature, only mammal, where the uterus, the vessels of the uterus actually embed into the placenta, or the vessels of the placenta embed into the uterus, and the blood vessels of the mother and the placenta intertwine, which is why there are so many more complications in human pregnancy, and also why human pregnancy has the brain development it does. It's because of this embedding of the placenta. And if you think about why there is such a change in the immune system and the importance of the placenta, you now understand why women with immune-mediated diseases have so many more complications of pregnancy. It has to do with the impact of the immune system on the placenta. Another important concept is that there's a receptor called the FcRn that is on the placenta and develops around week 14 of gestation. This receptor binds antibody and transfers from the mother's blood to the baby's blood. And because this doesn't really happen in the first trimester, we are not as concerned about the risk of biologics. So if there's a monoclonal antibody, we are not as concerned about the risk of birth defects because it's not going to transfer to the fetus until the second trimester, and most of the transfer occurs in the third trimester. So when a new biologic like risankizumab or gazolkamab comes out, I will continue it throughout pregnancy without concern for birth defects. Other things may happen, but not birth defects. Small molecules, on the other hand, like upadacitinib or ozanimod, will cross in the first trimester, and that's where you have concern for birth defects. So this illustrates the importance of the placenta. This is two patients who were given vedolizumab. Vedolizumab blocks alpha-4 beta-7, which can impact MADCAM. And MADCAM is involved in the process of placentation, or the placenta embedding into the uterus. This was a patient who also had pulmonary hypertension. This is a normal placenta. You see how thick it is. This is a patient who was on vedolizumab, but also had pulmonary hypertension, very abnormal. But if you look at this second patient, completely healthy, delivered at 39 weeks with ulcerative colitis on vedolizumab, it's still abnormal compared to the patient without inflammatory bowel disease. And so the question is this due to vedolizumab, or is this due to IBD? And one of the things we're looking at with Piano now is collecting the placentas of multiple patients on multiple drugs to try to better understand this process. And the reason I bring up the placenta is that women with IBD have an increased risk of preterm preeclampsia. This can be a significant risk for both the mother and for the infant. And there are two studies that confirm that women with IBD have higher rates of preeclampsia. This is why we recommend that these patients are followed as high-risk patients. Now, a study from Australia suggested that the use of low-dose aspirin in patients who are pregnant beginning at week 12 of gestation is associated with a reduction in the rates of preeclampsia. And so for all of our patients with inflammatory bowel disease, we do recommend that they're started on baby aspirin. In the United States, baby aspirin's 81 milligrams. In the trial, they use 150. So we generally use 162 milligrams, so two 81 milligram doses for these patients beginning between weeks 12 to 16. So when we talk about medications in pregnancy, it's important to remember that women with IBD are not included in clinical trials. And unmeasured confounding is innate to uncontrolled studies. The people that we continue on upadacitinib, continue on a new biologic, are generally sicker patients. Existing disease activity impacts the decision. There's low rates of adverse events, small sizes, and we have to understand that 5 to 8% of all pregnancies are associated with birth defects, and you have to separate that from the effect of the drug. When we stop a biologic, it's very clear that there is an increased risk of flare, and this was seen in a very large meta-analysis that showed when therapy was de-escalated or therapy was stopped before the third trimester, that there was an increased risk of flare. The biggest risk to the pregnancy is active disease. With active disease, you have higher rates of pregnancy loss, miscarriage, preterm birth, low birth weight, etc. And that's why, from a risk to benefit standpoint, we want to continue the medications for IBD. So when we think about medications, we think about 5-ASAs. They can be continued throughout pregnancy. If you're using sulfasalazine, make sure you give 2 milligrams of folic acid instead of just 1 per day. Thiopurines can be continued in pregnancy. Methotrexate is known to cause birth defects. It's a known teratogen. That should be stopped at least 1 month prior to considering conception. Steroids should be minimized because steroids are associated with an increase in adverse outcomes, likely related to the fact that there's increased disease activity. So if you think, I'm going to stop their new biologic and start them on steroids, chances are they're going to do worse than if you just continued them on the biologic. So now, with the global consensus, IBD experts on every continent agree you can continue anti-TNFs, anti-integrins, and anti-IL-23 agents throughout pregnancy. We do not stop it early. We don't stop it at week 32. We don't stop it at the second trimester. We continue throughout pregnancy on schedule. JAK inhibitors are more challenging, Often a patient on a JAK inhibitor like tofacitinib or upadacitinib are on it because there's nothing else that works for them. And so in that situation, you have a conversation with the patient and decide whether they want to continue it through pregnancy. And we have continued both drugs through pregnancy in our patients in our practice. The FDA came out with a warning about thiopurines. They reported in April of 2024 that there was a rare risk of intrahepatic cholestasis of pregnancy. The incidence in the general population is about 1%. IBD data from Australia and from the Netherlands and the United Kingdom also showed that this was increased with thiopurines. And things that they suggested was if you have a patient on a thiopurine, make sure you check their liver enzymes. If their liver enzymes are elevated, check their metabolites. Splitting the dose of thiopurine can reduce this risk of abnormal liver tests and intrahepatic cholestasis. You can consider allopurinol, though that risk safety in pregnancy is less clear. But just remember to be aware that this is a risk, a small risk with thiopurines, and be monitoring liver tests in patients on this agent. Risankizumab, so ustekinumab, we have fairly decent safety data, and we know that all of the biologics cross the placenta. We know that certolizumab has no transfer because it does not have the FC portion, but infliximab is detected in the infant at 2.5 times the human rate. Vedolizumab is less than in the infant than the mother, but what about risankizumab, which is new? This was just published in IBD journal. We looked at 3 patients who had transfer and showed, surprisingly, that the infants had lower levels than the mother. And this may have to do with the fact that the newer biologics are not as avidly bound to the FcRn. Some data on tofacitinib. This is across all programs. There were 85 maternal exposures, 99 paternal exposures, and in that there was no increase in adverse events. Again, very small numbers, but reassuring. For upadacitinib, the reason why upadacitinib is more concerning than tofacitinib is that birth defects were seen at 0.8 times the human dose of 30 milligrams, 0.6 times the human dose of 45 milligrams. So at the doses we give in humans, birth defects were seen in animals. In this study of 128 maternal UPA-exposed pregnancies, there was no increase in birth defects seen. Again, small numbers, and we generally try to avoid JAKs in pregnancy, but if there's no other option for the mother, we continue it. What about breastfeeding? So we talked about the principle of the FcRn when thinking about drugs in pregnancy. In breastfeeding, we think about the relative infant dose. A relative infant dose less than 10%, so the dose received by the infant compared to the mother, so a dose less than 10% is considered acceptable. When you look at the IBD medications, you have 100% of the drug in the maternal serum. Studies of maternal antibodies showed less than 1% in milk, of which 50% is digested, and then 0.5% is in the infant GI tract, of which 0.01% is absorbed. So the relative infant dose is far less than 10% that can potentially get in the infant. So for monoclonal antibodies, we feel comfortable with them continuing it through pregnancy. For azathioprine, we feel comfortable continuing it through pregnancy. For most drugs, as we said, less than 10% is safe, and all of the IB drugs are below that. For I have a study of tofacitinib, which I did not put up here, but for tofacitinib, the relative infant dose is higher than biologics. It's about 3 to 4%, so not greater than 10%, but we still try to avoid it because we're unsure of the effect on the infant. So we recommend breastfeeding as it's not associated with an increased risk of disease exacerbation in women with IBD, and we suggest that infants born to mothers on anti-TNF who breastfeed have no increased risk of infection. Oh, this is the tofacitinib study showing that the relative infant dose is 3.4%. So more than biologics, where it's 0.05%, but still less than 10%. We discourage women from breastfeeding, but if they wanted to, based on the relative infant dose, they could. No data for upadacitinib or filgotinib. So this is one of the summary slides from the global consensus. These are slides that once the paper is finalized, you will be able to download from the website in English and Spanish. Safe to breastfeed on all of these medications here. We recommend avoiding breastfeeding on these 3 medications due to limited data and concern for harm. So to summarize this part, there's reduced fertility with active disease and with surgery in the pelvis. There's no, these are some other questions I didn't have time to go into but wanted to summarize. So women who have active disease are less likely to get pregnant. If they have a J pouch, less likely to get pregnant. A lot of patients in the U.S. do egg retrieval. Our anecdotal experience is no increased risk of flare with egg retrieval. Women with IBD have a higher rate of preterm delivery and spontaneous abortion, particularly with active disease. And importantly, women with IBD have higher rates of VTE with pregnancy. So we recommend continuing all biologics and thiopurines throughout pregnancy and breastfeeding, avoiding small molecules with pregnancy and lactation, providing preconception counseling to improve outcomes, and low-dose aspirin for all patients with IBD. It has to be started between weeks 12 to 16, not associated with flares, and then perform a C-section for delivery if active perineal disease, rectovaginal fistula, or IPAA. This next part is shorter and just going through some of the guidelines. There's higher rates of NICU admission and hospitalization for the infant. There's higher rates of small for gestational age and low birth weight with active disease. But there's no increased risk of childhood malignancy, developmental delay with the use of biologics and thiopurines. Vaccines, there's some important data here that's new. We recommend inactive vaccines for all children on schedule. And we suggest that live rotavirus vaccine can be given to infants even if the mother was exposed to a biologic in utero. And I'll show you the data for that. However, relevant to Central and South America is that live BCG vaccine should be avoided in the first 6 months if the children were exposed to a TNF in utero. If it's a small molecule, you can give it after 1 month. Oh, did you need a picture? Okay. Inactive vaccines should be given on schedule regardless of any medication because none of them should impact inactive vaccines. Children exposed to JAKs or S1Ps can get live vaccines after a month, and live vaccines can be given to infants and mothers breastfeeding while on biologics regardless of the EMA recommendation. So this was a great study out of Canada. Well, this one was retrospective data. 309 patients accidentally got rotavirus despite infliximab exposure, no adverse events. But this study out of Canada was prospective. 191 exposed patients, 187 recommended to get vaccine, 168 got the vaccine with no serious reactions. And then looking just at IBD patients, because some of the other ones included RA, there was no harm in infants getting rotavirus vaccine on schedule despite the use of biologics in the infant. So there's an increased risk of IBD to the infant if a first-degree relative has IBD, increased risk of low birth weight if the mom has active disease, higher rate of NICU stay, higher rate of small for gestational age if mom has active disease, no increased risk of infant infections, malignancy, or developmental delay with biologic exposure, and infant vaccines should be given on schedule regardless of medication exposure. Live vaccines should be given on schedule except BCG, which can be given after 6 months. And if you have oral polio in your country, that's a live vaccine, should be given after 6 months. But inactive polio can be given on schedule. And that is it. I'm happy to answer any questions. Yeah. Thanks.
I'll ask you in English.
No, ask in Spanish so she can translate.
You want her to translate for you?
For in case people want to. Oh no, whatever.
But we're going to end up translating. Do you shy away from use? I'm going to talk in my talk a little bit about the S1P receptor agonist, right, for UC. Do you shy away from them in women that are like UPA is a little bit different, right? Because I think like I shouldn't say, when people are sick, they're sick and you need to use something. But for someone with a young one with UC of childbearing age, are you using S1P receptor agonists liberally?
Yeah, I go by the general principle that you should choose the best medication for the patient, whatever that is. And then if a patient is on an S1P, for example, if she's like, I have a flare and I want to get pregnant as soon as I'm better, I'm not going to pick an S1P. If she's 21 years old and says, I want an oral medication and has no plans for pregnancy in the near future, I would consider an S1P in that situation. So I do not avoid them in people who are of childbearing age unless they're immediately planning to have children.
La pregunta era sobre el uso de los S1P y la doctora Abreu preguntó si se evitaban en las mujeres que estaban en edad fértil. La doctora Uma dice que ella la puede utilizar en pacientes con edad fértil, excepto en aquellas que estén planeando un embarazo pronto.
You said that you recommend upadacitinib only if a pregnant woman has no other options. How do you go about navigating that conversation and helping her to feel comfortable continuing?
Great. So it's a challenging conversation. So I can give you some examples. I have a patient with severe Crohn's disease who failed all available medication, was on the Crohn's disease exclusion diet and UPA, but risankizumab came out. So I added risankizumab to the UPA and tried to wean her off the UPA, and I was able to, and she was able to get pregnant. So if I have another option, I will try. I had another patient who had failed all available medications, was in remission with ulcerative colitis on UPA, and we talked about pregnancy, and we said if you stop UPA, you may have a severe flare and need a colectomy. You can consider using a surrogate. You can consider other ways of starting a family. If you choose to get pregnant, understand there may be a risk of birth defects. We don't know. There isn't enough data. And I've had patients who've chosen to go ahead and continue on the UPA. So that's the conversation I had in much greater detail, but those are the key points.
Sobre el uso de UPA en pacientes que van a empezar una familia, entonces si hay una opción, se escoge otra alternativa. Pero si la paciente requiere UPA y es la única opción, la conversación va dirigida al riesgo que tienen de tener malformaciones congénitas esos bebés, porque no hay suficiente información para darle a la mamá y ya la mamá, una vez informada, puede tomar la decisión que le parezca correcta.
I just want to say that Dr. Fabian Juliao was one of the participants in the global consensus representing Central Colombia. Yes. Mm-hmm.
Hello. Thank you, Ma. Thank you for being here with us. And my question is, bueno, en español, mi pregunta es, lo ideal es, y lo recomendamos pues en la guía, es que la paciente con enfermedad inflamatoria intestinal logre estar embarazada en remisión clínica. ¿Ok? La tasa de remisión clínica en enfermedad inflamatoria intestinal no son del 100%, obviamente. Entonces, tenemos muchos pacientes que no están en remisión clínica, aún con los medicamentos que tenemos y después de intentar varios tratamientos, pero quieren quedar embarazadas. ¿Qué hacemos con esos pacientes? Le decimos, mira, definitivamente no quedes en embarazo, planifica, o le decimos, si puedes quedar en embarazo, pues miramos cómo te tratamos, así no estés en remisión clínica. O sea, ¿cuál es la recomendación exacta que debería hacérsele a ese paciente?
So Dr. Juliao is saying that the ideal recommendation is that a mom should get pregnant if she's in remission. However, the statistics don't support that because we cannot have all patients 100% in remission, no matter what medications we use. So what is your approach when you have a patient that is not in clinical remission and she wants to have a pregnancy. So should you recommend avoiding the pregnancy and starting a family a different way, or should you recommend just moving forward with the pregnancy and then managing the pregnancy depending on how the patient goes?
So that is very challenging. I do try to get them into remission as much as possible, at least clinical remission. If I cannot get them fully into endoscopic remission, but they're feeling well and are stable, then for them, that might be the best time. Somebody who's constantly on steroids, we have had patients have a colectomy during pregnancy because they got pregnant when they were ill, and that is not ideal. So if a patient gets pregnant while flaring, we treat them as aggressively as possible. But generally, we try to optimize them with all the medications that we have, including things like upadacitinib. I think it's safer to be on upadacitinib than to be sick during pregnancy. So we deal with what we have, but we try to get people into the best remission they can be. And I agree with you. I have patients who this is the best they've been the entire time that I've taken care of them. This is their window to get better. Yeah.
La respuesta de la doctora es que hay que tratar de llevar a las pacientes a remisión. Ella hace un tratamiento agresivo para llevarlas lo más cerca de remisión, así sea simplemente remisión clínica y no remisión endoscópica, porque ese puede ser el mejor punto en el que va a estar esa paciente de todo el tiempo, y aprovechar esa ventana para poder que la paciente empiece su embarazo. Pero ella ha tenido pacientes que reciben esteroides intermitentemente o pacientes que quedan embarazadas y hacen una exacerbación de la enfermedad y requieren colectomía durante el embarazo. Pero al final lo que dice es que ella no lo evita y que manejan a la paciente lo mejor que se pueda con los medicamentos que se pueda, incluyendo upadacitinib, porque el concepto de la doctora es que el uso de upadacitinib es menos riesgoso que una exacerbación de la enfermedad durante el embarazo.
Here. Hello. Thank you, Uma. You recommend against the breastfeeding when the patient uses upadacitinib or tofacitinib? Yeah, you don't recommend breastfeeding?
So if a patient is on upadacitinib or tofacitinib, we generally recommend they avoid breastfeeding because there does seem to be a significant amount of transfer. It was at least 3.4% to the infant blood, and there is a risk of infections and other harm to the infant. As I said, if it's less than 10%, it's considered acceptable. So if the mother really, really, really wanted to breastfeed, okay, but I tell them to avoid it. Also, it's important to remember that the breast milk of women with inflammatory disease may not be great. So if you're thinking about why should the mother breastfeed, there is bonding, but in terms of all the health benefits to the infant, if they have an inflammatory disease, the baby may not be getting any of those benefits. And I try to tell them that to help reduce the guilt as well. Some of the studies have shown that women with IBD have increased inflammatory cytokines in their breast milk.
La recomendación de la doctora es evitar la lactancia en las pacientes que usan upadacitinib o tofacitinib, teniendo en cuenta también que las mujeres que tienen enfermedad inflamatoria intestinal, la calidad de la leche materna en esas señoras es diferente a la de una señora sana, porque ha habido estudios que han demostrado citoquinas proinflamatorias presentes en la leche materna. Entonces, la calidad de esa leche materna es diferente y eso es parte de la conversación que se tiene con la mamá para disminuir la culpa.
Gracias, doctora Uma. Por favor, ¿quedó alguna recomendación o hay experiencia en vida real y en combinación de biológicos en embarazo y en lactancia?
¿Combinación de qué?
Biológicos. Terapia combinada. Dos
Do
biológicos.
you have a recommendation of combined biologics during pregnancy or breastfeeding?
Biologics, not thiopurine.
Biologics.
Yeah. So we do have patients who are on combination biologics and they continue it through pregnancy. We look at each individual drug and their risk to the pregnancy. So if they're on risankizumab and vedolizumab, both are considered low risk in pregnancy, we continue. If you're asking about anti-TNF and thiopurine, if the thiopurine is purely to reduce antibodies, sometimes I will stop the thiopurine in pregnancy unless that patient has failed a prior TNF, has a history of antibody, then I will continue.
Si la paciente está recibiendo un anti-TNF y vedolizumab o ustekinumab, el riesgo del uso de la combinación de esos dos medicamentos no es alto y se continúa durante el embarazo. Es diferente cuando se habla de la combinación no de biológicos, sino de un anti-TNF y tiopurinas, como azatioprina. Si se está usando la tiopurina para disminuir la incidencia de anticuerpos anti-TNF, entonces se descontinúa en esas pacientes durante el embarazo y la lactancia.
Gracias.
Thank you.